In this presentation, I would like to acknowledge Nina with her, she has been done an extraordinary job in co-leading the working group one with me, and she put it into a very schematic way, the work that we have been done so far. So our pre-assumptions were that sexual health as an integral part of a general health framework. So exploring human variations in sexual health functioning across Europe and paying attention, putting the focus on sexual health. Identify components of sexual health this research. This is the pathway that we have been through since our first meeting in Salzburg. We defined the components and levels to be considered in sexual health and sexual behavior research from the individual point of view, from an interpersonal point of view, from the society or community or at the country level point of view, and even inside the EU or worldwide, in fact. In relation to mental and physical health, with each limit, with defined limits, and the factors that may be variant from individual point of view, like age, religiosity, migration experiences, from an interpersonal point of view, like role functioning or dyadic relationship, from a country point of view, the diversity, the gross domestic product, its culture, the structure of domination, the participations and influence in politics, and from the EU point of view, the cross-cultural differences and similarities, and sexual health related policies. So we have to take these issues into account, and then we develop, and I acknowledge Ege and Charmaine for doing this template, which was used for our research in each topic. We defined the topic that we would like to look on, with a global overview of the problem, the scope of it, the background, which will justify the interest in doing research on this. And from literature review, we present some results of what it's important and what we should be research, and we identified gaps in research, and what can or should be done, and when. These are our topics: lifestyle and sexual health, with Marco Alves in the head of it; sexual health and basic research with Silvia Socorro; cancer health and sexual health and impact of cancer on partners' sexuality, very ligated to the previous one; HIV prevention and sexual health; sexual education in the digital space; sexual education; sexual violence and sexual health; and disabilities and sexual health. These are the topics in which we are working on. So the MAP research agenda and goals. So our research agenda goes from research related to sexual health, from the basics, risk factors, like the topic on molecular and cellular basis, the topic on sex in the digital space or on lifestyle, to translational topics with intervention developments, like the topic on sexual violence, to treatment, to rehabilitation after sexual violence, for example, and dissemination with topics on the AHV and disabilities or oncosexology. This is an overview of our research goal mapping, which we are managing with working group 2, and Nina is establishing the bond with Lota. And these are the key themes, again, individualized with key concepts, key definition, objectives, research goals, and key target groups, which are defined for each topic and be more extensively presented during the next hour. To finalize, this is our big picture with main goals: the magnitude of the problems, the likelihood of impact on the landscape of them, and the interest in economics and politics, with a special focus in high prioritized groups like adolescents, aging population, LGBTQI community, HIV infected people, people with disabilities, people with cancer. These are our main focus. And this is our overview from working group 1. I would like to ask if someone wants to say something. Marianne is following us in every meeting, so you are informed of what's it's going on. So no, I don't know if anyone else would like to make a comment on this.
I would just say it's an excellent overview of the action of Working Group 1. Fantastic. You couldn't have brought it better together. Congratulations. And also congratulations,
yes.
Nina Heinrichs. And what I also wanted to mention, I also wanted to thank Paul Enslin, who is also involved in Working Group 1. And I just wanted to, he's also a co-leader. I just wanted to mention that
yes.
too. Thank you to Paul too.
I would like to acknowledge Nina in this particular presentation because the schematic part belongs to her. She have done an extraordinary job putting in this very comprehensive schemes what we have been the route that we build up so far.
Yeah.
Excellent. So I would like to pass to topic 2. Indeed, it's topic 1 to be presented. Lifestyle and sexual health with Marco. Marco Alves will present lifestyle and sexual health.
Okay, good afternoon. Are you hearing and seeing everything? Okay, thank you. Good afternoon. My name is Marco. And first of all, I would like to ask you to send me an email or something if you have some questions, because unfortunately, I will have to leave in 1 hour or so. I will not be able to be in all the meeting because is also the Portuguese Society of Diabetology Congress. So, and I'm there also giving a lecture this afternoon. So I'll talk about lifestyle and sexual health. We heard this morning Lion talking greatly about this, so I will not bother you a lot, but I will give you an overview of our template that we have prepared. First of all, let me just give you a conflict of interest. I'm a little bit of an outlier here because I have a PhD in biochemistry, so I am a lab guy. So my view is a little bit different from some of you, but I find it very useful for me. At least I'm learning a lot with you guys, and I'm very grateful to be here. So regarding our topic, I will give you a concept and context, and then the method and how to include information in the something we have prepared, and what we would expect as an outcome of this work. First of all, the concept. You have heard it this morning, so I will not bother you a lot, but you know that lifestyle, it's a way of living that lowers the risk of being seriously ill or dying early. This is according to the World Health Organization. And also sexual health as a state of physical, mental, and social well-being in relation to sexuality. It is clear that both definitions have a common sense, but there are many dimensions that you can consider for both. So taking that in consideration and also all those reports from the World Health Organization, we selected these dimensions here regarding infertility, psychosomatic aspects, endocrine disruption, sexual dysfunction, reproductive disease, and also sexual transmitted infections that we also heard this morning a little bit. And clearly, lifestyle is present in all aspects of sexual health. So what is the main objective of this work? It would be to identify the risky lifestyle behaviors across member states. Of course, we have challenges, the specificities of each territory and of each discipline. And the solution would be to have cost action sexual medicine network involved and all the experts giving their expert opinion. So how? We would ask members of each country to complete a table-like survey to identify the most significant lifestyle factors affecting sexual and reproductive health aspects in their countries. But most of all, I think that most importantly, it would be this is not a population view, but the experts' view, the multidisciplinary view regarding these risky factors. So we would have a table that would be disclosed regarding the expertise and also the country, of course. We have the lifestyle factors here, and then we have the sexual and reproductive health aspects we were talking about as dimensions important in this topic. And how to fill this? It will be a qualitative scale 1 to 4. 1 would be not significant, 4 would be extremely significant for each topic. Let me give you an example and explain more rapidly how you would do this. So if you have taken in consideration psychosomatic aspects, let's start with dietary habits because we have lots of data regarding that. I would say that in Portugal, it is a 4, extremely significant. Why is that? That is because the last big statistics were from 2014, and we know that 59% of men and 48% of women were obese. This, of course, represents a risk towards metabolic disease, but also body self-image issues. So there is a strong correlation between dietary habits and psychosomatic aspects of sexual health in the Portuguese reality. This is how I would justify my number. So another quick example is the physical activity and sedentarism. I would also say a 4 because Portugal has a high rate of insufficient physical activity. And there is a positive relationship between physical activity and body images. So I would say this is as high as metabolic disorders. But this is my perception as a biochemist. Some of you may have a different perception regarding the statistics, and that is also very relevant. So what would we have from this table? We have data regarding each territory and the different experts. We could have a statistical analysis and proper discussion from those data that we could collect and different expertise discussion from the regional perspectives. So this is only added value to this report or paper that we could write concerning lifestyle and sexual medicine across countries, but most effectively regarding different experts. So how to move on and what would I do if I should put this working? An email sent to all the participants of the cost with a few time for completion, 2 months, 3 months. There's some gap in the time as you see because we always have to delay it. The validation of data, check if everything is fine and the justifications are okay. Let participants know if there are problems because this is important. Then data handling, validation because statistical analysis will be very difficult and I don't know how much persons we will have to do this. Discussion of data in small groups regarding this multidisciplinary expertise. And then we have all participants discussing data and researchers invited to write parts for a final document or no. So this is just an overview how I would do it as a milestone. So I would like to know is lifestyle and sexual health perception different between countries and the different specialists? So this is the main question that I would like to give you and for discussion. So thank you very much. Should you have any question, please put forward.
Thank you, Marco. Thank you, Marco. I would like to, in reply to a question by Ethel, I would like for you to please send all the questions that you have to each subgroup leader. I can be in CC. We only have a little bit more than 6 minutes for each presentation since Ege can't present his topic and we'll have a little bit more. But since we won't have time for discussion, please send your doubts and questions to each sub-leader, each leader of each subtopic. Right now, I will present my topic. cancer and sexual health. So why is it important? Oncosexology, it's a relatively new area of specific knowledge which aims to increase the awareness of sexual issues in oncologic care and stresses the importance of addressing these issues to prevent the development of sexual dysfunctions, problems, or worries. This intervention system encompasses a team of interdisciplinary professionals. Why is it important? Because cancer is a major public health problem, and mainly in developed countries in which the EU is included, where we've seen that cases are much higher than in the rest of the world. So I'd like to address that prostate in men and breast in women they respond for the vast majority in each sexual cancer, and they respond directly to those what we called genital cancers, but also colorectal cancer and lung, colorectal, which is a pelvic cancer, and lung, stomach and liver, which are very frequent as well. I would like to underline the cervix uteri as well as a genital cancer. Then we have the hematological cancers like leukemias and lymphomas, or testicular cancer, which have a very high incidence in youngers, and head and neck cancers, which are less frequent, but have a very important impact on the body self-image. Fortunately, the survival of to cancer, it's increasing thanks to the emergency of advanced treatment modalities for cancer and the development of the healthcare system, specifically in prostate and breast, which are directly related to sexuality. Sequela might be just temporary, but it can be irreversible as well. As doctors and healthcare professionals, our role is to now need to see beyond the horizon in what cancer matters. We have to anticipate the side effects and their treatment. The background is that the cancer as a disease can have a negative effect on the quality of life on both patient and partner. And they tend to cause a decline in the patient level of functioning and also on their partner. There seems to be a lack of information about cancer and sexual health for patients and partners, and this field of oncological care has only recently been recognized. An interesting thing, as a result of cancer, between 7 and 22% of couples may separate, and these divorces may be directly linked to the sex unavailability of the patient. And no approach in cancer deserves to be called holistic as long as sexuality and intimacy have not been adequately addressed. So we performed a literature review on PubMed for the last 5 years, which, as I said before, it's a relatively new area of interest. So these are the most interesting articles that they were published in the last 5 years. We looked also in some books published in the area, considering the different dimensions that I previously reported on the overview. And the results, there are many publications concerning genital and sexual cancers with direct impact on sexuality, like prostate cancer in males or breast cancer in females. But there's a lack of studies about the impact on sexuality of non-genital cancers. Cancer patients would welcome information about sexual matters, and some of them report feelings of abandonment and not being taken seriously. If sexuality is mentioned in the early stages of treatment, the sexual outcome may be better. Sexual well-being benefits the recovery and healing oncological process, and this is very important in the treatment process itself. And there are some cancers that affect and treatments that affect almost all patients, like hormonal treatments in prostate cancer and breast cancer, or surgery and radiation in pelvic cancers. And another thing that's important is that there's a lack of healthcare professionals training in the field of sexual medicine, and even more in the specific field of oncosexology. Even in terminal stage of cancer, being questioned about sexuality and intimacy makes patients feel that they are still seen as alive or as sexual human being. And there's a big lack of research in the palliative care population, which has a high prevalence of sexual dysfunction at that time. Even professionals like medical oncologists dealing directly with cancer patients, they assume that barriers for avoiding discussion the sexual function were lack of time, lack of training, and advanced age of the patient. From a study in patients after hematopoietic stem cells transplantation, this study reported that higher sexual education after the transplantation improved couple sexual health. And there's some information about cancer and sexual health from oncological societies, but they lack addressing lesbian, bisexual, transgender, and gender non-conforming needs. What can or should be done? It's important to promote multidisciplinary teams, especially in cancer treatment centers, education for professionals and patients in this area, filling the gap in research in heterosexual and LGBTQ individuals concerning cancers other than prostate and breast. For policymakers, it will be important to underline the need for free of charge access to sexual rehabilitation protocols after cancer treatment. And cancer should be treated in dedicated centers prepared for dealing with it in all dimensions of the disease and ready to rehabilitate patients to their normal life, to their life as normal as possible. Questions to be raised in our network. What is the accessibility to an oncosexology multidisciplinary team in different EU countries? What are the inequities between EU countries related to the cost of treatments? Are men and women equally treated? Are there sexual and gender identity differences? Is the partner also addressed? So the specific in-country programs related to oncosexology, if any, they can be reproducible in the rest of the EU country members. And we hope to deliver input from different members about their own country examples, about oncosexology and mapping differences. There's in question a booklet in different languages directed not only to professionals, but also to patients. There are some examples in the internet, but not as specific as we want to do. The development of an online site about oncosexology at an European level for patients and professionals, and online seminars, and this will be in collaboration with Working Group 3 and 4, and a manifest for policymakers stating reasons and evidences about the benefits of sexual medicine and oncosexology for oncology patients. Also, as presented before, we intend to do some animated videos for our network site and for the future network YouTube channel. Thank you for your attention. So it's now time for Evie to complement my presentation, reporting the impact of cancer on partner sexuality.
All right, can you see my screen?
Yes, yes, Evie.
Okay.
Go ahead.
All right, so there seems to be a problem in the literature because in general, the partner perspective is usually not emphasized. However, partners of patients with cancer have been seen to have very high rates of anxiety and also depression. So this is data from a very recent systematic review that took into account 30 other studies. Sometimes depression of the partner was double of the depression seen in the patients with cancer. Different factors were associated with the mental health of the partners, like their own problems and so on. But actually, the more they were connected to the patient, to the relationship, the less was a depression. So this emphasizes the importance of taking care of the relationship. Now, if we see here, we can see that the stress levels, the anxiety levels of the partner, this is at the moment of the diagnosis, more or less it remains the same after about 1 year. And if we look at the depression of the partner, then the depression is actually decreased in 1 year, but it can still remain above the clinical cutoff. So it is important. This is a very nice study, which is recent, but we had a similar one a few years ago, where actually what we saw was that the patient's depression, the patient with cancer, I mean, when they have depression, this influences the stress of the partner, and the partner's stress then in turn influences the patient's depression. So the patient with cancer and the partner, they have a spiral sort of interaction. So sexuality and physical intimacy have been shown to be important both to the patient and to the partner. Couple closeness and support help to make the experience of cancer more manageable, seems to assist the recovery process. This is some data that I have chosen to show you, where more or less what this shows is that the majority of partners said that cancer had an impact on their sexual life, and it had actually decreased or ceased their sexual activity. In many occasions, it's not that they had just stopped having sex, but they had also stopped any kind of physical intimacy between them. And only very few had actually managed to renegotiate their sexual activity and intimacy with their partner. So there are several studies showing, qualitative studies showing the difficulties that partners face. So for example, this was one study saying that the reasons why they had stopped having sex and enjoying sexual pleasure was because they felt that the patient was more or less like a child that needed help, so not very sexy, or they felt reluctant to initiate sexual activity and to express their sexuality. In another study of partners of men with prostate cancer, one of the interesting findings was that the emotional intimacy without pursuit of sexual pleasure through sexual activity was considered to be insufficient for the recovery of sexual intimacy. So emotional intimacy was not enough. They also required more sexual intimacy. So it seems that the couple needs a lot of help to renegotiate sexuality and sort of like design it again and start off from the beginning, finding what works. This is a systematic review looking at diets versus patient and partner studies. So in most studies, they look at the patient or the partner separately and not as a diet, not as a couple with interactions. So targeting spousal caregiver patient diets rather than individuals was shown to be more beneficial. So it's important to have interventions and studies that look at the diet instead of each separately. So what is available? Well, basically, we had a look at the literature and we saw that only very few studies were specific on partners of cancer patients and relevant to their sexuality. And also very few were specifically designed to assess the sexual needs of partners, and also very few evaluated interventions to address the sexual needs of partners or couples. Another problem that we found was that the studies use different kind of outcome measures. So there is quite of a mess, and it's very difficult to compare the study. There's a lack of coherence. Also, male partners may have different needs to female partners, and therefore relative research studies should not be combined. And partners could derive medium effects for improvement in sexual relationships from couple-based interventions. So what could be done is a conceptual framework explaining the sexual satisfaction of the couple facing cancer. This conceptual framework could actually guide research and could also guide clinical practice. The focus could be on the spouse-patient diet facing cancer. It could be inclusive of all cancer types, all aspects of sexual well-being, not limited to sexual dysfunction and coital sexual practices, and of course, partners of both genders. So this is it.
Thank you, Evie. Excellent presentation. And we move forward to HIV prevention and sexual health. Valeska Padovesi will present this topic.
Hi, thank you for the introduction. I present on behalf of Rafael Ballester, who prepared this PowerPoint presentation. We thought we had just a few minutes and only 4 slides, so we were very brief in our presentation. The background, the facts, we know that HIV still represents an important concern in public health, despite the advance in medical treatment. You know that nowadays antiretroviral treatment manage to fully suppress the viral replication in patients living with HIV. And prevention remains the key issue. Numerous biomedical interventions have been recently.
I do not see the presentation. Sorry to interrupt.
Sorry, I thought I shared my screen. Wait.
Yeah, you shared your screen, but you did not open the PowerPoint, I think.
Yes, I'm showing my
Perhaps,
PowerPoint.
yeah, perhaps you shared another part of the screen. Valeska,
Okay.
when you put
Yeah, we can see it now.
there it
Are you
is.
seeing? I don't know what
Yes.
I did. Sorry.
Yes.
So
Now we can see it. Yes. Thank you.
okay, I keep on going. Sorry, I'm sorry. So I was talking about the prevention, which is a key issue in HIV through biomedical intervention. Now I'm not seeing my screen. I don't know what happened. Are you
And we're
seeing
not as well. Yes. Again.
I
Yes.
don't know what happened.
Perfect.
So biomedical intervention, so PrEP, post-exposure prophylaxis, and treatment as prevention. And we therefore stress the importance of focusing on risk sexual behavior, which has maintained the main role in the HIV transmission among European countries. And the aim of our proposed research is that to promote sex education programs, both in the general population and in the so-called vulnerable groups or key population. For key population, we intend people who inject drugs, men who have sex with men, commercial sex workers, and undocumented migrants, and people living with disabilities. So here in this slide, there are the different aspects that our research should be touched. From the epidemiology, so quantitative study, epidemiology of HIV in the general population, in the key population, by age group, gender and sexual orientation, safer sex practices like use of condom in the different sexual practices for vaginal, oral and anal sex, dental dam, in lesbian women, the implementation of PrEP, effective implementation of PrEP program. And I must say that ECDC has recently launched the PrEP guideline for European countries. So this is very, very new. So we can also rely to data already existent from the European Center for Disease Control. The distribution of PrEP in Europe is free of charge. We know that not all the countries in Europe give free access to PrEP. The HIV testing update, including the possibility for patients to have access to point-of-care tests or rapid tests for HIV and eventually other STIs. The availability of antiretroviral treatment in the country as free medication, free for all, and also in respect of some specific groups like migrants, especially undocumented migrants. If there is a sexual health policy in place in the country, and what is the level of sexual health education offered in school, in the different level of education in different moments of the lifespan. The access to condom and contraception in the country, and emerging issues, mainly chemsex, so the use of some specific drugs to enhance sexual activities during group sex in MSM mainly, so in the LGBT community, barebacking, the group sex and use of dating apps, mainly Grindr, data availability on effectiveness of HIV prevention program in each country, and if there are cultural factors or legislation affecting HIV prevention in the country. The methodology is based on the literature, in the literature review, and on an online survey that should be sent out to the cost action member states to collect data at the country level about the main aspect I have just listed in the previous slide. And the expected result should be published in different in article or in different report and distributed in Europe to the different stakeholders. And I think with this I have concluded my presentation. Thank you.
Thank you, Valeska. We move forward, and we perhaps we can have some discussion time for the end. We will move forward to sexual education. Barbara Meyer.
I will do the presentation on behalf of
Miriam.
Barbara Meyer.
Okay, go ahead, Miriam.
So, our theme was sexual education in school books. My name is Miriam Ho. I'm working with Barbara Meyer in the Clinic Ottakring in Vienna. The background of our topic was that in Austria, every 5th woman is exposed to sexual violence before her 15th birthday. There are similar numbers, I think, in the other member countries of the European Union. And as we all know, sexual education is a very big part of prevention of violence against women. And so we wanted to look on the sexual education, which is crucial to begin in early age in the kindergarten and in the school. Our scope was to look how sexual education is done in kindergartens and in schools. Also an assessment of the pedagogics knowledge and skills in this area, and how the education is implemented according to the guidelines from the WHO. We did a survey. There we screened school books and educational material according to the WHO guidelines in Austria, and we want to do a study also in other European countries. The results of the screening in Austrian biology school books was that there was missing and deficient information about STDs, HIV, about contraception and abortion, also missing and deficient information about the anatomy and function of sexual organs. Almost 60% of the pictures showing the female genital were incorrect. And there was no information about sexual rights, about pornography, about media use and cyber grooming and topics like this. There was also a lack of information about the handling of menstruational products, of condoms, of other contraception products. Sexuality was only presented as a topic of procreation. There were no topics about eroticism and feelings. They hardly play a role in the school books in Austria. And also a lack of diversity, so no examples of homosexuality, no information about trans identity, intersex, and also no cultural information about practices like circumcisions, etc. So what needs to be done? We need to do further screenings of the school books, not only biology school books, but also religion and ethics in Austria and in the other COST countries. Based on the results, we want to do recommendations to improve the educational material so that they go along with the guidelines from the WHO and educate the educators. Thank you.
Thank you, Miriam. We move forward with a topic on sexual violence. Stephanie Booth will present the topic.
Yeah, thank you, Bruno, for the introduction. Can you all see my screen? Yeah. Okay.
Yes.
Together with Germaine Borg, Marcus Bote, and Nina Heinrichs, we worked on the topic of sexual violence and sexual health. First of all, why this topic? Oh, he doesn't move. Yeah. Well, as you all know, and it has been noticed before, sexual violence has a high prevalence and can have a serious impact. It can result in physical damage such as injuries, unwanted pregnancies, and sexual transmitted infections, but also in profound psychological damage. And the damage can be the result of the violence itself, but it can also be the result of harmful experiences during the process of reporting. And of course, it can have a serious impact on sexual health. We reviewed the literature and, if we summarize it, we see also in Western countries high rates of sexual violence, especially in women with female factors. So in Western surveys, about 20% of the women report that they experienced rape or attempted rape during their lifetime. And women also report, 18% of the women report to have experienced childhood sexual abuse, and 8% of the men report childhood sexual abuse. Mostly the perpetrator is male, and it is seldom a stranger. Because most often the perpetrator is somebody the person knows. And also victims of child sexual abuse have a higher likelihood of experiencing sexual violence later in their lives again. So there is re-victimization, which can be really a big problem. Furthermore, we know that the history of sexual violence is associated with mental disorders such as PTSD, depression, personality disorders, and substance abuse. And we also know that the history of sexual violence is associated with sexual dysfunction, not only with problems of aversion, low desire, arousal, orgasm, and pain problems, but also with compulsive and risky sexual behavior. Based on the literature, we noted some understudied areas, important research topics, and we think it may be helpful to work together on a European level to study these topics. First of all, we should know more about the interaction between mental and sexual disorders. How do they influence each other? We should study more on the risk factors of re-victimization, an important topic. Also, we think we should study the availability, possibly also in different European countries, the availability of help for sexual disorders for victims of sexual violence. There are indications, for example, from research that even after successful trauma treatment, after sexual abuse related trauma, sexual problems can still persist. And it seems that in mental health care, there is not that much attention for sexuality. So it may be the case that victims are treated for PTSD, but still experience sexual problems and lack help for such problems. Furthermore, there's really a lack of good empirical evaluation of programs for that are intended to improve sexual health in victims of sexual violence. So that's also a very important research topic. And furthermore, there are some groups, minority groups, which really need more research, such as male victims of sexual violence, but also victims of conflict-related sexual violence, for example, refugees in European countries, and also more research in sexual and gender minorities. And as a subgroup within COAST, we are working on write an article about these subjects and also these missing topics. And we are working on research plans on these different topics. And well, if you have any comments, if you have suggestions for further research, or if you want to collaborate, please let us know. Okay, thank you for your attention.